you, Aarti?
We do. I mean, I've only had a few cases where it was specifically for that purpose, but I've
same here. We've one particular urologist who likes to do all of them. So he's the one who sends us cases. And there's not a whole lot written up in the radiology literature. So I think if anybody else has cases, we could all try to pool these and write something up even. We have a few cases, so I just want to give a little background intro. So just most of us know these are used for treating male stress incontinence, especially in prostatectomy or TERP patients, or other causes of incontinence like a neurogenic and post-traumatic incontinence. So this is what the setup looks like. So this is the inflatable cuff. This is what's going to go around the urethra and hold it in place. This is the pump, which goes in the scrotum, which patients can manually activate. And then this is the reservoir, which is supposed to be intra-abdominal in front of the bladder. Typically, they put in the pre-vesical space. And depending on surgeon's preference, they can fill this with either normal saline or a little bit of contrast to make it higher density. So this is what the normal setup looks like. And when the urologists place these, they put it in an activated position. So the cuff is inflated. So patients don't experience incontinence. And whenever patients have to urinate, they automatically, the cuff deflates when they press the pump, and that's how it works. And based on timing from surgery, they divide complications of these AUS into early and late, early being less than 30 days, more delayed being more than 30 days. So you can see many mechanical causes for failure, but several other anatomic causes too, more in the late failure category. And then some unrecognized causes where the incontinence may have been from a mixed mechanism and you've not addressed that issue. So these are some, very little I found in the literature. So I'll just show some cases that we have. So these are different patients I have. We can start with this one. So just to take you through, I think all you need are high-res 3-plane T2s. No need for contrast, no need for any other sequences. We do a 3D isovoxel space sequence because the reservoir has to be seen, and that'll give us, the tubing in these cases can be so convoluted and tortuous, it helps us follow the tubing if we reformat on the space sequences. So we do those. So this was case one. You can see the scrotal pump up here. And then here's the cuff coming up. So the two sides of the cuff have to be coapted to each other. And then the most important thing to make sure is that the urethra distal to the cuff does not have any T2 bright signal like it has urine. So this is okay so far. But then when we look at where the reservoir is, anybody wants to tell me where they think this reservoir is? Definitely not in the pre-vesical space. So this one went.
Yeah, so Rajesh is saying obturator canal.
It's actually in the pectineus.
Yeah, it's in the muscle.
It's in the muscle. It's, yes, playing these. Know how this happened at the time of placement, obviously. So maybe a slight miss. The reservoir was completely out and just sitting in the pectineus muscle. In this case, they had to go back and reposition this reservoir, make it be in the normal pre-vesical space. Patient also has a suprapubic cath here. So till they fix this, they had him.
Is it normally threaded through any of that musculature to get up to the space? So therefore, like it pulls?
I don't think so. It should just go through the inguinal canal. I don't know how they misjudged and went so much laterally out. Okay. It should just come up here through this, and then the bulb should just sit here.
Do you know if the patient had any symptoms?
He did. He felt a groin bulge every time he had to. This was inflated, so that's how. Yeah. So this one, the tubing was okay, the cuff was okay. This was a problem with a misplaced reservoir. Then this next case, maybe I'll show this one first. So in this case, we see a very obviously dilated urethra distal to the cuff. Here's our cuff. just looking at it, it looks like it's coapting, but may not be perfect, or we wouldn't expect this much dilatation in this part of the urethra. And then when we tried to follow and I'll show you sagittal images, when we tried to follow this tubing, this seemed like, so here's the tubing coming up, the left inguinal canal. It came up here and sort of abruptly ended at the level of the inguinal ring. And what we see here is this squiggly low T2 signal band-like tissue, no other reservoir that we could find. I'll show you haste images of this same thing. So we did a big field of view trying to look for the reservoir, never found a reservoir anywhere else. This was just some fat. So this one ruptured. So this was a remnant of whatever the walls of the reservoir were. So this patient also went on to get a replacement, and this time they went on the right inguinal canal and placed his reservoir on the other side. So it's just a nice case of a ruptured reservoir. And then last one.
Rupa, I have a quick question.
Yeah.
And that one you showed the urethra dilated proximal and distal to it. And proximal,
Yeah.
I would presume that the bulbar urethra is going to kind of dilate over time because it's like, because you have that sphincter more distally.
Right. So this probably had a component of cuff failure also, right?
Yeah. So this one you're saying,
or I don't know if it's the pressure. It's a pressure issue that
the cuff wasn't tight enough, so therefore urine was
yeah,
dilating.
this may have been a dual thing. Yeah, but definitely the reservoir in this place was the bigger problem. But yeah, the fact that this is dilated, it's either itself too. And this was just another milder example of an incompetent cuff. And this is another issue we see. Many of these patients also come with implantable penile prosthesis. So it gets very confusing to follow the tubing on these patients. And then you'll have two sets of reservoirs also. So on this one, again, space images were really helpful to follow that this belonged to the left side. And then we were able to follow it. And in this one, we see very little dilatation of the urethra distal to the cuff. So the tubing was intact, the reservoir was okay. But in this case, more of a cuff failure issue. So this also went on to get a cuff replacement. And then the continence issues improved. So just a few abnormalities in the spectrum of what we see on these patients. So not seen too many of these, but seems like an interesting entity for the urologists.
Yeah.
And that is all I have.
That's great. I had one recently where actually it was on a CT scan and
Okay.
the tubing and the reservoir were filled with air.
Oh.
And our hypothesis was that maybe they had accidentally filled it with air when they were instilling it because we couldn't figure out any other way that the air got in. And
that's actually something they say in the surgical technique is the urologists have to make sure there is no air in the system when they install it. So yeah.
Yeah, because we were thinking first maybe infection, but the patient wasn't having any symptoms like that.
Right.
So yeah, it was interesting. And the patient could feel air crackling when he was trying to inflate it.
Right.
So,
Yeah.
cool.